Athletic Injuries and Psychology, Chapter 20. There is a pretty significant cost of injury associated with athletic and exercise participation annually. Americans sustain an average of 8.6 million sports and recreation-related injuries per year. In children ages 5 through 14 years, 2.78 million sport and recreational related injuries resulted in trips to the emergency department. Data from Sweden also shows that 75% of elite soccer players will sustain an injury sometime during a season. After injuries, such as a knee injury involving the anterior cruciate ligament or ACL injury and reconstruction, return to play can be an extremely long process and is disappointingly low, with 1 in 3 athletes failing to return to sport. Physical factors are the primary cause of injury, but psychological factors can also contribute. Injury is defined as trauma to the body or its parts that result in at least temporary, but sometimes permanent, physical disability and inhibition of motor function. This may involve an individual participating while still feeling pain, so that attention is needed due to the pain. There is a loss of or a change in function due to the injury, and a decision process takes place about whether to continue participation. What causes injury during sport? This is a multifactorial issue. Physical factors include factors such as muscle imbalance, high-speed collisions, overtraining, and physical fatigue. Social factors include attitudes and norms such as the perception by performers that playing with pain and injury is seen as highly valued in our society. Psychological factors. Personality factors such as a history of stressors and coping influence the onset of injuries, as does an athlete's psychological skills. Personality factors. To date, a direct link between personality factors and athletes' injuries has not been consistently demonstrated. Personality is thought to be involved with injuries in more complex ways, interacting with factors such as stress levels. Our next factor is stress levels. People with high levels of stress have more sport and exercise-related injuries. Lastly, we have genetic factors. Individuals may be predisposed to injuries based on the way they are built anatomically and genetic factors as well. As we approach treatment and rehabilitation, it is essential that we understand the 3-phase process of rehabilitation and recovery. First, we have the injury or illness phase, then a rehabilitation and recovery phase, and then finally a return to full activity phase. Each phase dictates different approaches to the psychology of recovery. During the injury or illness phase, we focus more on helping the athlete to understand the injury. During the rehabilitation or recovery phase, we will focus our attention on helping to sustain motivation and adherence to rehabilitation protocols through goal setting and maintaining a positive attitude. Finally, the return to activity phase. Although an athlete is physically cleared for participation, complete recovery does not happen until normal competitive functioning occurs. Athletes with higher levels of life stress experience more injuries than do those with lower levels of life stress. 85% of studies verify this relationship. The majority of studies link negative life event stress with injuries, but in some studies, positive life events can also cause stress and therefore increase the rate of injury. A number of factors are involved in the stress-injury relationship. Athletes at high risk of being injured had fewer injuries after stress management training interventions than their high-risk counterparts who did not take part in such training. The greatest stress source for injured athletes were not the physical aspects but the psychological ones, such as the fear of re-injury, shattering hopes or even dreams. Research shows that teaching stress management techniques may help athletes and exercisers perform more effectively and may reduce their risk of injury and illness. The stress-injury relationship is complex. In a classic study by Smith and colleagues in 1990, they found that life stress is related to injuries only in at-risk athletes, those with few coping skills and low social support. Individuals with low self-esteem are pessimistic and low in hardiness and have higher levels of trait anxiety. They may also have low mental toughness and low familial support systems, and have higher levels of daily hassle and decreases in daily uplift experiences, resulting in more injuries. There are several ways to explain the stress-injury relationship. First, attentional disruption. Stress disrupts an athlete's attention by reducing peripheral attention and causing distraction and task-irrelevant thoughts. We also see increases in muscle tension. High stress can cause muscle tension and coordination interference, as well as generalized fatigue, muscle inefficiency, reduced flexibility, and muscle coordination problems. Other explanations for stress-injury relationships include overemphasis on acting tough and a give 110% attitude, failure to distinguish between normal discomfort and the pain of injury. Sometimes athletes report a coaching attitude of "you're injured, you're worthless," which also affects that stress-injury relationship. Also, sports ethic norms, values, and the environment in which winners never quit and quitters never win, and bravery, bravado, and machismo lead to denial of pain and injury. Psychological stress increases catecholamines and glucocorticoids, which impair the movement of healing immune cells to the site of the injury and interfere with the removal of damaged tissues. Prolonged stress may also decrease the actions of insulin-like growth hormones that are critical during the rebuilding process. Stress also causes sleep disturbances, another factor identified in interfering with physiological recovery. Concussion has received increased attention in sport, the mainstream media, and scientific research communities because of the devastating stories about professional football players who sustained concussions, although we're seeing this across every single professional and collegiate sport. 9% of high school and 8% of college athlete injuries are concussions. Concussion injuries are not just a problem in elite sports. Approximately 1.6 to 3.8 million concussion injuries occurred in competitive and recreational athletes. A concussion is a complex pathophysiological process affecting the brain induced by biomechanical forces. A concussion may be caused by either a direct or an indirect blow to the head, face, neck, or elsewhere on the body, with an impulsive force transmitted to the head. Females compared to males have a greater risk of concussion in comparable sports and are 1.5 times more likely to sustain a concussion. Multiple concussions may cause short and long-term impairments. Some of the common signs and symptoms associated with concussion include headache, dizziness, fatigue, drowsiness, sensitivity to light and noise, feeling slowed down, mental fogginess, difficulty remembering and concentrating, sadness, nervousness or feeling more emotional than usual, vomiting, numbness and tingling, trouble falling asleep, and sleep disturbances. The best treatment for concussion is still rest. Academic accommodations, such as more time on test or maybe even time away from a computer, vestibular and ocular therapy, cognitive behavioral therapy, and sometimes medication. Most symptoms for 80 to 85% of all concussions are resolved in 7 to 14 days, but some athletes remain symptomatic for much longer. There is an emotional response to injury. We call this the grief response. While cited in earlier work, injured athletes have not been found to move through these inflexible fixed stages. These stages are sometimes referred to as the DABDA stages. They include denial, anger, bargaining, depression, and acceptance or reorganization. Three general categories of emotional reactions to being injured include injury-relevant information processing, emotional upheaval, and reaction behaviors. The goal is to end with a positive outlook and coping of the injured athlete. Most people experience a typical response to injury, but the speed and the ease in which they progress through the stages can vary widely. The period immediately after the injury is characterized by the greatest negative emotional reaction for the individual. It is important to understand other injury reactions may occur as well. Things such as identity loss. When athletes can no longer participate due to an injury, they may have a loss of personal identity. That is, an important part of themselves is lost, which seriously affects their self-concept. They may also have fear and anxiety. When injured, athletes can have high levels of fear and anxiety. They worry about whether or not they will recover, if re-injury will occur, and whether another teammate will replace them permanently in the lineup. Because the athletes cannot practice or compete, there is plenty of time for worry. There may be a lack of confidence, given the inability to practice and compete, and deterioration of their physical status. Athletes can lose confidence after an injury. Lowered confidence can result in decreased motivation, inferior performance, or additional injury because the athletes overcompensate. We may see performance decrements. Because of the lowered confidence and missed practice time, athletes may have post-injury declines in performance. Many athletes who have difficulty lowering their expectations after injury expect immediate return to a pre-injury level of performance. And finally, group processes. Although injury is generally seen through the eyes of the injured athlete, injury to an athlete can affect the group processes within a team either negatively or positively. Not everyone who sustains an injury adjusts to that injury well. There are signs of poor adjustment to athletic injuries, feelings of anger and confusion, possible obsession with the question of when they can return to play. Sometimes we see denial. For example, this injury is no big deal. Why can't I go back? Repeatedly coming back too soon and then experiencing re-injury. Exaggerated bragging about accomplishments. Dwelling on minor physical complaints, sometimes pain or a lack of range of motion. Guilt about letting the team down. Withdrawal from significant others. Rapid mood swings, and statements indicating that no matter what is done, recovery will not occur. When abnormal emotional reactions to injuries are identified, a referral to a sports psychologist, a counselor, or other qualified mental health professionals should be made, just as should be the case if an uninjured athlete exhibits general life problems, such as things like depression, severe generalized anxiety, or any other mental health concern of a clinical nature. So, what are the roles of sports psychology in injury rehabilitation? A holistic approach is needed, with an emphasis on healing both the mind and the body. Psychological factors play an important role in injury recovery. Psychological factors such as self-talk, goal setting, and self-motivation also positively affect adherence to injury treatment protocols and rehabilitation. Injury treatment should include psychological techniques to enhance the healing and recovery process. Some 90% of certified athletic trainers report that it is important or very important to treat the psychological aspect of the injury in addition to the physiological aspect. Athletes will not automatically transfer psychological skills used during athletic participation, such as imagery, to the injury rehabilitation situation. Research has shown increased outcomes for athletes who are using imagery during their rehabilitation from athletic injuries. These athletes most often used imagery while observing practices, while driving, or at home in bed, although I would advise not closing your eyes for imagery while you're driving. The athletes used imagery to rehearse rehabilitation exercises, improve performance of certain exercises, facilitate goal setting, facilitate relaxation, control anxiety, motivate themselves to engage in their rehabilitation exercises, maintain a positive attitude, and maintain concentration. It is important to remember that physical healing does not necessarily coincide with psychological readiness for return to activity. There are specific predictors and enhancements of adherence to sports injury rehabilitation. Things such as personal attributes, which may include pain tolerance, tough-mindedness, self-motivation, and athletic identity. Environmental characteristics, which include social support, practitioner expectations of adherence, comfortable clinical settings, and convenience of scheduling of appointments. We also have effective adherence interventions, such as reinforcement, goal setting, education, and multimodal interventions. And lastly, predictors of adherence: rehabilitation self-efficacy, personal control over injury recovery, emotional distress, treatment efficacy, and perceptions of injury severity. So, what are some of the guidelines for providing social support? We need to build a rapport with the injured party, take the athlete's perspective, and provide emotional support, but be realistic and positive and optimistic. Provide social support to athletes. The sources of social support can also include individuals such as coaches, significant others, and medical personnel. Athletes generally turn to coaches and medical professionals for informational support and to family and friends for social support. Social support needs to vary across the rehabilitation phases. The need for social support is greatest when setbacks occur and when other life demands place additional stress on an individual. While generally helpful, social support can have negative side effects as well, such as when support providers do not have a good relationship or have credibility with the athlete, or when support feels forced for either party. Learning from injured athletes by understanding the recommendations injured athletes have made about facilitating recovery and rehabilitation. We need to ensure injured athletes are psychologically ready to return to play by having sports medicine professionals work in conjunction with coaches and other allied healthcare personnel to make sure the athletes are psychologically ready to return. We need to systematically address both physical and psychological factors during rehabilitation, making assessments of psychological readiness to return to play by considering factors such as confidence, realistic expectations, motivation, and the fear of re-injury. The recommendation for the injured athlete: try to accept and positively deal with the situation. Focus on high-quality training and set your goals. Remember to write goals down. Recommendations for sports medicine personnel: educate and inform athletes about injuries and rehabilitation. We want to foster positive, professional interactions and customize our training, and demonstrate competence and confidence in all situations. Our recommendation for coaches: foster a coach-athlete contact and involvement even after injury. Demonstrate positive empathy and support for the injured athlete, and try to avoid constantly mentioning the injury during other training sessions.